Yeah. So hello everyone once again. Today I'm gonna be sharing with you one of those cases that I think is interesting. And for the purposes of this discussion, I'm hoping that by the end of this discussion, we'll be able to use the clinical information that we're going to avail ourselves to help us arrive at a diagnosis. I'm hoping that we'll also, after arriving to a diagnosis, we'll be able to review the pathophysiology underpinning the diagnosis of this case discussion that we're going to share, as well as finalizing with the management of the strategies, management strategies. So our case, we start off with a 62-year-old male who is admitted with breathlessness, productive cough, thick yellow sputum. You take a good history. His past medical history includes anxiety and nothing much more. He's usually independent in terms of activities of daily living. He's a non-smoker and only drinks socially. Proceeding into his examination, you notice that he's slightly drowsy. His febrile 38 degrees. His SATs, when the ambulance crew come in, they said that his SATs were 85 on room air. You auscultate and he has a bit of coarse crackles with a mild wheeze. He's a little bit tachycardic. The BP on the lower side, as you can see. No evidence of peripheral edema, and he has dry mucous membranes. Now I'm going to go to comments. If we can go to the comment section, and how would we proceed? What would be the things that we would probably do? How would we manage this patient? If I can go to the chat function. Yeah, so if we type into the chat function, see, how would we proceed? Yeah, so Hannah, so can see chest x-ray from Josh. Yeah, chest sepsis, cover for chest. Very well. Very well. I'll put that. Buffalo for sepsis, very good. Liana, very good. Okay, very good. So cover for chest. We are doing a chest x-ray. Anything else in terms of blood test? Yes, somebody blood test, VBG. Yeah, I think we've covered most of the things there. Very well. We'll continue. Very good. So his SATs were 85 on room air. So we give him oxygen. We give him antibiotics as you've suggested. Give him some fluids. Buffalo, as it's already been mentioned. Some paracetamol as well. Blood tests come back, and his CRP, those are the blood tests. His CRP is quite raised. Chest x-ray, you're not seeing much. And somebody asked for a blood gas. Yeah, so we have an ABG with a pH of 7.25. The PCO2 is 7.5. His PO2, so this ABG is done on room air. Can we see any? I think, yeah. So Dominic, we've done an ABG and that is on room air. Very good. Hannah, so we see that he has a type 2 respiratory failure. Very good. How do we proceed in managing this patient? What things? So we've given antibiotics, CPAP, trial medical intervention for an hour. Yes, Hannah, good. So the thing we need to be mindful is that, as we're giving oxygen, we need to be, yes, if not working, then an NIV. Yeah. So the thing I wanted really to prime there is, we start to think whether there is scope for NIV for this patient, given the fact that he's retaining. And I think, is that Dominic has already mentioned, yeah, he's having a type 2 respiratory failure. Do we think that is acute, chronic? So he is having a type 2 respiratory failure. Yeah, bicarb normal. Yeah. Yeah, so we think he's probably gone into a type 2 respiratory failure, but of an acute nature. Very well. Thank you. So, yeah, we give him, so the UNEs are okay, the chest x-ray, not bad, nothing much. So he's got a leukocytosis, a raised CRP. We think, he's got some form of a chest infection, and he's got, a mild acute type 2 respiratory failure. So we give him some, he's a bit wheezy. So we add on bronchodilators. He's in type 2 respiratory failure. We don't commonly see this in typical pneumonias. We give him some steroids. We give him some mucolytics. We've given him oxygen. We've given him some IV fluids. We've taken off blood cultures. An hour, as somebody suggested, we see that, there isn't much response. He's actually getting worse, getting more drowsy. We repeat our gas, and our gas, the new pH is 7.15. PCO2 has even climbed up to 10. You can see that the PO2 is actually no problem, but he's getting more acidotic. So he's not really responding to our treatment. And the next thing, we want to think, should we go, we need to be thinking about non-invasive ventilation or invasive ventilation. He didn't respond to NIV, ended up, he was just deteriorating, ended up going to ITU. He had a good functional baseline and was ventilated. He was extubated after 24 hours as weaning of his intubation. He was put on NIV for about 12 hours and then stepped down to a level 1 bed. You go to review him. The GCS is 15. His SATs are 96 on room air. His respiratory rate is okay. You do gas, things are looking all right. He was bringing up, struggling with phlegm. We asked the chest physios to review him. He's had mucolytics. He has a neuro exam and nothing. Everything is looking all right. So he's accepted on a level 1 bed. You're called 12 hours post step down that this gentleman is again unwell. He's looking very drowsy, quite breathless, less responsive. You do a gas and it shows a severe type 2 respiratory failure. He is not responding to NIV, and he ends up being re-intubated, again, taken back to ITU. So if we go to the chart, so far, I'll go to the chart again. So far, what we have is a gentleman with no clear past medical history, nothing very significantly standing out there. He's coming with a form of chest infection, going into type 2 respiratory failure, not responding to medical therapies, being intubated, extubated, re-intubated. Any thoughts so far that differential things that might be crossing your mind at this point before we proceed? Yes. So a typical GBS, yes. COVID, good. Well, I should mention that this was before the COVID era. Yes, but that's a very good suggestion. Certainly in this, yeah, COVID, right? Dominic, yeah. Anything else? ARDS, Harrison. Okay, very good. Good differentials. Shall we see? Let me check the participants, how many we are. I'm seeing only like 2 people responding. Any differentials, or everybody's thinking about those 2 things at the moment? Okay. Yeah, fair enough. We'll go with those. We'll go with those 2. Seems like people, it is tied up between a typical GBS, COVID, and ARDS. So those are the things at the moment that are in our minds. So because of uncertainty of the diagnosis, this gentleman is behaving in a relatively unusual way. You go to review the history, and what you find that he was admitted. He'd been, so you review you take a closer, you review the history to see if there is anything you're missing out. And what you note is that he'd been admitted for 3 days, 3 months prior to the, the current admission. He'd been admitted in a type 1 respiratory failure. He'd lost weight for the 6 months preceding the current admission. There was no history of falls, no family history of no family history of, similar ailments. You ask one of your neurology registrars to take a neuro exam. He does power, the neuro exam comes back, power is okay, sensations, muscle tone, planters, nothing is significant. You do a CT chest, make sure it's not paraneoplastic issues. So the differentials here, we're thinking of, could it be a paraneoplastic problem? Lambert-Eaton, one of them. So you do a CT and you find that he's got a pneumonia with mild bronchiectasis. You go do thorough examination and you find that this gentleman has tongue thinning, fasciculations, and dysarthria, which is more conspicuous on this occasion. So I think at this moment, we should be able to inform our diagnosis a bit more. I've gone back to the chat function and I'm seeing Millie, yeah, motor neuron disease. Very well, very well. Millie has been following. Very well. So, with the fasciculations, I think I've not seen any other suggestions. I think I would have to agree with Millie and with most of you now that there are no other differentials coming in. If anybody, so this gentleman is likely having motor neuron disease that has presented with respiratory failure. If anybody has, most of you will recognize that face. One of the chaps well known to have suffered, Stephen Hawking, who suffered from motor neuron disease. Those of you who have not watched Theory of Everything, I would urge most of you to watch it. So this gentleman had a full neurology review and was diagnosed with motor neuron disease. We just remind ourselves of what motor neuron disease is and how it fits in with the presentation of this gentleman. For those of you who have done respiratory rotations, you probably are aware that some of these conditions are actually first diagnosed. Most of the, a good number of neurologic conditions are first diagnosed with respiratory failure on the respiratory units. And when we're on call, when we're on our wards, we should be probably something we have at the back of our minds that some of these neurological conditions might come through as respiratory failure. And if things are not tying up very well, probably it's the neurology that is at fault. So if we review a quick review, I'm sure we've all done this, so it's going to be as interactive as we can because I'm sure it's not necessarily new, but how we make, we're going to try to see how we make use of existing knowledge to inform and advance our practice. So a quick review of the motor neuron disease is a group of, chronic, sporadic, and hereditary neurological disorders that are characterized by progressive degeneration of motor neurons. So I think the salient words there are chronic in nature, sporadic, and hereditary. Majority of them are sporadic, just happen without any hereditary background, without any family history. If you remember, in our gentleman, we took thorough history when he was behaving in an odd fashion, but he had no family history. But just because, so if he had a family history, probably would have suspected it earlier on. But it's important to remember that M&D actually majority of the cases are sporadic in nature. The other word is progressive, gets worse in time, unlike other neurological conditions like multiple sclerosis that have remitting episodes. That is not characteristic of M&D. It's also, so it is mainly a disease of the motor neurons and spares the sensory neurons. Largely speaking, different organizations classify M&D in different ways. Well, one is the mode of transmission, like, whether it is sporadic or inherited. I find this one useful because it gives us a good understanding of anatomical description. It gives a good anatomical basis. So I've taken off time to draw this, what I think is a lovely summary of the neurological anatomy and how it fits into the categories of motor neuron disease. If we go through, I've got using the cursor. So if we review our neuroanatomy, that is the word, we know that if we start off, we know that the motor neurons are the main targets for motor neuron disease. We know that it usually spares the sensory neurons. We start off, with the motor cortex. If we look at the frontal motor cortex area, we know that our nerves come through there and come to, the midbrain. So we have the, this is the spinal cord. So we have through the midbrain, through the pons, through the medulla oblongata, and then they decussate through the spinal cord, coming up to the anterior horn. This is where they're coming out to go to innervate the muscle. The target is, for motor effect onto the muscle. But this is the general pathway. So we know that we have from here the motor cortex. Down here, we have the cortical spinal tract. We know from the anterior horn, this is what we call the lower motor neurons, up to the peripheral nervous system, innervating the muscle and asking the muscle to do whatever the muscle is responsible for. We also know that in the medulla oblongata, if we look at our cranial nerves, we know that the nuclei of the last 4 nerves, that is 9, 10, 11, 12, we know that they are they reside in there. So we know that, so this is for the normal, this is the corticospinal tract, peripheral nervous system for normal muscles. And then for cranial nerve muscles, we know that we have the bulbar tract system. So we have the cortical bulbar tract, which is coming with decussation through the medulla oblongata, and this is the lower motor. Number 4 is the lower motor part to the cranial nerve that is being to the muscles, to the muscles of the face or muscles of swallowing. We know that we know that cranial nerves 9, 10, 11, and 12, they are more for the tongue, palate, soft palate, tongue, pharynx, and larynx. This is where they reside. So when we're talking about number 4, those are the muscles we are talking about. This is the muscle, for example, your hand. So I've used different colors to sort of break it down. So if we look at the red, according to that nomenclature, so if we have motor neuron disease that is affecting the peripheral nerve, that is, the red color that is coming from the anterior horn to the muscle. If we have the disease affecting, targeting, damaging those nerves and causing motor deficits in the peripheral nervous system of the nature from the anterior horn to the muscle itself, that one is called progressive spinal muscle atrophy, as shown in red. And then we know that if it affects the upper, this one we also call it the lower motor. So so progressive spinal muscle atrophy is gonna present predominantly as a lower motor neuron, physical examination reveal. If it affects the corticospinal tract anywhere there, which is marked by 2, this is what we call the primary lateral sclerosis, and that is upper motor neuron lesions based on this tract, which I find quite easy and useful. If we have the so-called amyotrophic lateral sclerosis, that is the combination of 1 plus 2 giving us 3. So there is numerical order in that. That was not the plan. There is a numerical order in that. So far at this level, we know what we can't tell by examining the patient. We can tell whether they fall into any of these 3 categories, knowing that here they're going to be having lower motor neuron signs. Number 2, we know they're going to be having upper motor lesion signs, and here a combination. Number 4 is the lower motor of cranial nerves, which we call the bulbar palsy. And the green one, so number 4 is the blue, so it's the equivalent of number 1, but when we're talking about bulbar palsy. Bulbar means, medulla oblongata, whether when the lesion is in the peripheral of the cranial nerves. And the green one, lastly, pseudobulbar palsy, if the lesion is in the corticobulbar tract. Number 5 here, if the lesion is anywhere from there to here, that gives us so corticobulbar tract. If the lesion is there, it's going to give us pseudobulbar palsy. So this is the anatomical basis, and given that we already have had a teaching from stroke, which was very useful, I attended and I found that useful as a person who does GIM as well. I'm sure that you already know what signs are for upper and lower motor neuron lesions. And that makes it very easy for us to be able to examine and categorize patients who present with MND. So the etiology, what causes the motor neuron disease? I think the honest answer is 1, we don't know. However, there are many theories that have been put forward. There are several hypotheses, some with variable acceptability, but the exact cause we do not really know. There are a few things that have been associated with motor neuron diseases, like in the genetic one, where there is a hereditary component. There is people who have suggested different genes, as you can see. There is people who have suggested environmental basis. It's common in people who are, smoking cigarettes, in athletes. If you've had cyanotoxins, there is some hypotheses that are relating to the military service as well. The truth is we don't know the exact cause. In terms of epidemiology, we know we've looked at the different ways using neuroanatomy, how we can classify motor neuron disease. And the commonest is the amyotrophic lateral sclerosis, with over 2/3 of patients presenting in that category. As we discussed, it is both upper and lower motor neuron. And the other commonest is progressive bulbar palsy, and then the progressive muscular atrophy. If we count that, so primary lateral sclerosis and pseudobulbar palsy should be having a very small proportion. If I count that is already 35, which is almost already 100. So the biggest proportion of patients you and I are likely to come across are likely to be in the amyotrophic lateral sclerosis or progressive bulbar palsy. But there are others, cases, as we've looked at the neuroanatomical basis. So to put it in context, in the United Kingdom, the Motor Neuron Disease Association, that is as per late last year record, it estimates that 1 in 300 of the general population will suffer with motor neuron disease through around their lifetime course. The prevalence is about 5,000 people living with MND in the UK at any one time. Now, going a little bit more about pathophysiology. So we've looked at the neuroanatomical basis of the different classifications. We know that motor neuron diseases, we are seeing that it is the motor neurons that are being targeted. But what some of the proposed mechanisms, some of the proposed hypotheses that are generally accepted, one, there are mainly two hypotheses. One of glutamic acid mediated excitotoxicity, and another one of the mutant protein aggregations to prions. So I've put up a slide here to sort of summarize this. We have here one nerve synapsing with another. We have microglia in our cell bodies that work as immune mediators. They are immune mediated cells. Astrocytes, the same. Now for synaptic, this is the presynaptic and this is the postsynaptic. We know that nerves to communicate from one to another, they use a wave of depolarization. They use neurotransmitters. So glutamate being one of them that has been implicated in motor neuron disease. And what we do have is the normal without motor neuron disease, you should be having glutamic acid being released from the presynaptic and goes into the postsynaptic motor neuron, causing calcium-mediated depolarization or a wave or signal, whatever you call it. And then you have this glutamic acid, is my cursor here. So we have this glutamic acid. Once it's caused a wave of depolarization on the postsynaptic neuron, motor neuron, it should be able to be absorbed by the astrocytes so that you do not have constant excitation of the postsynaptic motor neuron. So one of the theories that is well appreciated is failure. So if this failure of glutamic acid to be absorbed in the synapses, so it should be normally absorbed by the astrocytes. Obviously, for the glutamic acid to be absorbed by the astrocytes, there is a protein receptor that should cause conformational changes so that glutamic acid is absorbed. And for reasons that are unclear, we know that something happens to this receptor and it closes off the absorption, the clearance of glutamic acid in the synaptic space. So what we do have is increased presence of glutamic acid. So if you see this arrow, small arrow, followed by a big arrow, that is to represent increased levels of glutamic acid, causing exaggerated signaling, exaggerated excitation of the postsynaptic membrane of the motor neuron. And the wave of, the excitation is calcium mediated. So we have excess calcium secretion in the motor neurons, and this causes damage in the apoptosis in the motor neurons. So one of the drugs that most of you might have heard of, Riluzole, is meant to target glutamic acid at the presynaptic membrane to ensure that less glutamic acid is being produced. And it is not a complete cure, but there is evidence that it somehow prolongs, gives good benefits, as we'll discuss in later. So that is one of the common theories that is that has been advanced and accepted for motor neuron disease. The other one is the one of prions, for one reason or another. So the prions, we know that they are able to cause damage. They can cause abnormal protein foldings in motor neurons. Same basis for CJD and abnormal protein folding, damaging, causing lysosomal organs to burst, releasing the enzymes and causing cell death. And once they are released, these prions, they have the ability to go and attack the immune system of the nervous system, that's the microglia, cause similar abnormal signaling and death and release of altered glia metabolism, release of noxious chemicals that can damage directly the motor neurons, or that those noxious substances can actually damage the astrocytes and impair the glutamic acid. So this is the pathway. So directly through the microglia and affecting the cells, or through the astrocytes and causing conformational changes in the receptors for glutamic acid and leading us back into glutamic acid excess in the synaptic spaces. So this is the pathophysiology, and that is, it's the basis for Riluzole, which is one of the drugs that is been noted to give us the best benefits for patients with MND. And obviously the changes, we move from a normal cell that was innervating a muscle and causing contractions to a sclerosed cell that is unable now to function very well and cause muscle contraction using the mechanisms we've discussed there. So I think I've been talking for like endless minutes. So now that we've gone through, at this moment, where are we? Just to to recollect ourselves. We've talked about the presentation of this gentleman. We've walked from respiratory issues to knowing that the exact problem for him was actually motor neuron disease. We've reviewed the neuroanatomical basis as well as the membrane pathophysiology at the molecular level. Now, if we move to the history and physical features of the ALS, that is amyotrophic lateral sclerosis, which we said, is a combination of both upper and motor neurons. Considering that we're coming even from the stroke chart, from the stroke talk, I'm sure people will be able to go, if we go to the chat room, if we go to the chat, so from features, what would we expect in terms of ALS? What things can we expect now that we know the neuroanatomical basis of what ALS is? Shall we check what people would expect in terms of physical presentations, clinical signs? Guttering, okay, Dominic, right? So peripheral weakness, fasciculations, wasting, very good. So, Millie, it seems you're doing a neurology rotation. So we've talked about peripheral weakness. Yes, fasciculations and wasting. We've looked at, why there's going to be wasting. We know that if you do not use a muscle, you're going to lose it. So, there is reduced stimulation of those muscles and they're going to waste in due course. Good. Any other? So these fasciculations, these are predominantly all lower motor neuron signs. Okay. Anybody, any charts? Anything you'd expect? So foot drop, frontotemporal dementia, right? Anisha, I'll come to frontal. You're very right, but we'll come to that as well. I will come to that. If I don't, please remind me to comment about it. Okay, very good. I'll go off the chart. So we expect, because it's a combination of upper and lower, we expect some hyper. So from the upper, we expect a combination of both. Hello, is somebody saying something? Do we want to mute? Thank you very much. So we have hyperreflexia, spastic weakness, and we know that that is going to be, in essence, if you have the target at the cortical spinal tract, as we've already looked at it. We have lower motor neuron lesion manifestations, as Millie has already suggested. Distal muscles, initially, usually asymmetrical. We now know respiratory features like CO2. So we know that if it affects the muscles of the, we have the peripheral muscles, but also the muscles of breathing, like the diaphragm, intercostal muscles. That is how we get a ventilatory problem and we get CO2 retention and respiratory failure. That is one of the ways. There are other things we'll talk about. So if we go, the next one we said that was very common was the PMA, primary progressive muscle atrophy. If we go to the chart, so we said earlier on, progressive muscle atrophy is going to be looking at from the anterior horn to the peripheral nerve. In what sort of features would people expect? If we go back to the chart, yeah. So people, if you know, a person is presenting with a PMA phenotype of MND, what sort of things would we expect? No messages. So lower motor neuron signs, like, yes, I agree, Hannah, like, shall we have lower motor neuron signs, for example? So muscle wasting, yeah. Weakness, good. So yes, reduced reflexes, very good. Now that question is not for Hannah only. Shall we see other people? I've seen asthma on. Yeah, reduced tone. Now this weakness is a very good. So remember that we're going to be having weakness, whether it is upper or lower. But what nature of weakness are we going to be getting in lower motor neuron? So whether it is upper or lower, it's going to be weak, but it's different type of weakness for upper and lower. So reduced tone, yes. What type of weakness? Flaccid, yes. Flaccid paralysis, as opposed to spastic paralysis. Thank you very much, Dominic. Right. So I'll leave the chat again and go back. I hope I put them. Good. So we have the lower motor neuron type. We've talked about the proportion earlier, 20 to 30, progressive flaccid paralysis, as Dominic has already mentioned. The reflexes, I don't know if somebody said, what sort of reflexes do we expect? Let me just check the chat if somebody has commented. So reduced reflexes, I think that was Hannah. Yeah, totally right. Reduced reflexes. Yeah, fasciculations, and somebody has already mentioned asymmetrical weakness, asymmetrical weakness, mainly in the distal limbs. It has a better prognosis and slower progression. On average, I think the consensus is from diagnosis to time of death is about 3 to 5 years for people who have been diagnosed with motor neuron disease. Before we go to treatment and management, I think a couple of other things. It's important to note that although it affects motor activity, it commonly spares the eyes. The eyes are commonly, so people are able to see whatever they want to see. They are able to move. They don't get ophthalmoplegia. Bladder function is preserved. Bowel function is also preserved. So the sphincter motor activity from the sphincters is preserved. If some of you have watched Theory of Everything, he went on actually to give birth. So sexual function is usually preserved. Now, somebody mentioned about, I can't remember, I think it was Ankunda, Anisha. You mentioned about frontotemporal dementia. Yes, so our understanding is increasingly changing, and is just not purely motor. There is, movement understanding to show that it's actually a spectrum of other conditions that, involves probably more than the motor neurons. So yeah, Ankunda, you're right. But generally, this is what we know for a long time. And we have not probably formally shifted, but that is something that is increasingly being recognized. So probably another talk in 5 years or 10 years will be defining it differently. Yeah. So treatment and management, just trying to see, we have about a few more minutes, 5 minutes, make sure that we are finishing on time. Going to be trying to be on time, Dr. Thacker, this time round. So if we move to treatment and management, we've already mentioned that there is no cure for motor neuron disease. There is only this riluzole that can help. There is evidence that it helps to delay progression of disease by about 3 months. There is evidence for increasing tracheostomy-free survival. The dose is 50. I don't know the use of that. I don't think any of us is going to prescribe that. But we've already looked at how it works. We know that it reduces glutamic transmission, and it is at the presynaptic side. We've already known that excessive glutamate is, causes calcium-mediated excitotoxicity to the nerves, and that is the mechanism for the riluzole. There are a few other drugs, antioxidants that have been suggested. Evidence-based is a bit here and there, but it's worth knowing that there are a few other things being developed. So the main treatment is really, if we can't cure it, it's going to be supportive management. And when we talk about supportive management, what are we looking at? The main issues, one is spasticity, things we can help with spasticity. So there are tools that can be used to sort of objectively assess how spastic somebody is. We've measured them, numerical rating scale, spastic responses, modified Ashworth. We can use non-pharmacological methods to address spasticity, like a physiotherapy. There are also drugs that can be used. And for 30 seconds, because we are running out of time, anybody mention any drugs and any drugs that they know that can be used? Baclofen, yes, that is the commonest. Very good. Baclofen, that is the commonest drug that is being used. Yeah, so baclofen, number one. Others, gabapentin, there is evidence for gabapentin, tizanidine, benzodiazepines, and levetiracetam that can also be used for spasticity. Cialorrhea, that is, lots of secretions. Many people actually succumb to respiratory failure because they're unable to, remember we talked about bulbar palsy. One thing that I almost forgot, that many times the M&D can start off as a particular kind, but they always progress. So there is an overlap of all the classifications we've looked at, but most of them are going to have bulbar symptoms, or pseudobulbar symptoms in terms of swallowing. They're going to be, they can't clear the secretions very well. So there is need to manage these secretions, and some of the things that are used are anticholinergic drugs, atropine, hyoscine. So remember, on our patients, when we are doing palliative management of patients, end of life, remember we prescribe some of these, hyoscine, glyporate as well. There is other ways to manage that. They can do salivary gland radiation. They can use botulinum toxins injections to manage the salivary glands. And then to sort of move these secretions, there is a role for chest physio mucolytics. The other problem is, remember, the swallowing problem we've talked about. People can't swallow very well, so they will need dietary changes. Thickeners, just like our stroke people. So, we might have to give them low volume, high calorie diets. There's a role for PEG lines, sitting them in, posture when they're feeding, so that they do not aspirate, because aspiration is one of the causes, the major cause. Almost everybody, well, majority of people die from complications of that. The respiratory system, remember, respiratory system, we have the muscles themselves, the diaphragm being weak, the accessory muscles, intercostal muscles getting weak, but we also have reduced cough, loss of ability to cough, and respiratory insufficiency. So there is a role for cough assist devices. NIV, as we talked about, it increases, quality of living, it increases survival. These are the different indications. In some people, there is need for tracheostomy, and sometimes if the diaphragm is too weak, there is a role for diaphragmatic muscle pacing to help people live longer. Dysarthria, this is a problem of, So dysarthria is a speech problem, as opposed to dysphasia, which is a language problem. Now that is my alarm that I should be finishing now. I promise I won't go more than 2 minutes. So dysarthria, as I was saying, is a language problem. The patient knows what they want to say, they just keep struggling with forming the word, as opposed to dysphasia when which is a language problem. So, and why is this? Because of the bulbar symptoms we've talked about in the medulla oblongata, the last nerves, the tongue problem, the pharynx, the larynx, the soft palate. So 80% of patients during their course are going to develop dysarthria. So they have a speech problem. And if you remember with Stephen Hawking, he had customized software. So speech and language are very useful in supporting. Other things to be looked at include like muscle cramps because of the spasticity. There is role for quinine sulfate, mexiletine, that when Dr. Thacker looks at it, he's thinking about ventricular tachycardias in the role, but it is also useful for muscle cramps. Levetiracetam appears also to help, apart from the spasticity we talked about, it appears also to help. There's evidence for muscle cramps. They cannot move, so there is a role for painkillers. They're going to be in pain because of pressure sores. So different things have been used. Physiotherapy improves stiffness. They might develop contractures. So basically, they are going to, it's about support relating to the complications. Now, generally speaking, although we've said that FTD can be a component, most of them have a preserved memory. They are aware of, they are aware that they can't do many things and they get depressed. So there is a very good role of neuropsychiatric interventions, psychologists, and antidepressant medications. Lastly, palliative medicine intervention. This disease, as we said, on average, it is 3 to 5 years from diagnosis to death. The case of Stephen Hawkins was an exceptional one. There are different views for that, which I'm sure some of you might be aware, but it's also good to plan to support the palliative phase, because, it's going to be coming. Things like advanced care planning, community palliative services, having anticipatory medications, which we talked about, and addressing caregiver burden, the nursing burden, as they are completely dependent. They have a high nursing burden. And then when even they pass on, the families might need bereavement support. I believe that was my last slide. And in terms of the summary, what we've gone through, I think we've, had an appreciation of how respiratory failure can be caused by neurological pathology through this presentation. I hope we've gone through the basis, pathophysiological and neuroanatomical basis for the assessment and suspicion of motor neuron disease. And finally, we can see that, you need a multidisciplinary approach to try and manage these patients, especially in the context of lack of a cure. Thank you very much, and gone over by a couple of minutes. Thank you. Back to you, Dr. Thacker.
Are there any questions for Joseph?